Tetralogy of Fallot is a very complex heart defect that consists of 4 heart problems. These 4 heart problems are pulmonary stenosis, right ventricular hypertrophy, ventricular septal defect, and an overriding aorta. Some children are born with the 5th heart defect, which could be an open foraminal valley or atrial septal defect. This is developed in the womb and can be seen before birth. Tetralogy of Fallot heart defect causes oxygenated and deoxygenated blood to mix between the right and left ventricles. This is caused because of the ventricular septal defect. Babies born with tetralogy of Fallot are sometimes called blue babies because of the lack of oxygen, causing them to look cyanotic. 3 to 6 out of every 100,000 infants can be born with tetralogy of Fallot. Risk factors are unknown, but it is commonly seen in children with Down syndrome. Lifespan considerations. Children with tetralogy of Fallot may need to limit their activities depending on their oxygen levels and severity of the defect. The inability to grow appropriately is also a factor because of the lack of oxygen. Children are also going to need to do regular follow-up appointments with their pediatric cardiologist, and even after surgery, they will continue to see the cardiologist. They may require repeat operations. Nursing assessment and interventions. Hypercyanotic episodes, also known as TET spells, can cause a sudden increase in cardiac output and venous return associated with crying, feeding, or strenuous activities. This may be life-threatening if not corrected quickly. It is important to teach knee, chest, and squatting positions to help with the TET spells. Also allow rest periods between care, provide oxygen, and assess for failure to thrive. It is important to teach the family to provide rest periods while feeding and completely stop feeding an infant becomes cyanotic or is having a TET spell, and place the infant in a knee chest position. It is also important to assess O2 saturation, and it is also important to monitor for any fever, chills, seizures, headaches, or mental status because these children are also at a risk of developing brain abscesses. Diagnostics and labs used to identify the condition. Chest x-rays can be done, ECGs, endocardiographs, and cardiac caths. They cannot help reveal the severity of the anatomical defects. Labs done are hematocrit, hemoglobin, ABGs. They can also do a cardiac MRI, which can help identify the severity of any structural defects. Clinical interventions used to treat or manage. Management of the hypercyanotic episodes, TET spells, is to place the patient in the knee-chest position, calm the child, give them oxygen, and administer IV morphine and propranolol. You also have to monitor for metabolic acidosis or prolonged unconsciousness. Children with tetralogy of Fallot will have to have surgery done. The temporary options include a stent that is placed to provide adequate blood flow to the lungs by opening the pulmonary stenosis. Another temporary option is providing a shunt that can provide better pulmonary blood flow to the lungs. Corrective surgery can be done, and it is done at around 12 months of age. Surgeons correct the ventricular septal defect with a patch, also open the right ventricle by removing some of the thick muscle, and they also remove the obstructive pulmonary valve and enlarge the pulmonary artery branch if needed. Alprostadil is a medication that is given mainly to newborns with severe tetralogy of Fallot and with major pulmonary valve defect. This helps open ductus arteriosus, and it is received as an infusion. Children born with tetralogy of Fallot can live a long life, but may need recurring surgeries throughout their lifespan.